Good evening, everyone. On behalf of Indian Association for Bronchology, I invite you all for this webinar, which is the seventh in the series of the Basic Bronchoscopy Certification course. There will be 12 webinars and then one hands-on workshop in every zone of the country. This time we are going to have five. To get this certificate, I would request you to attend, or it's compulsory to attend at least 10 webinars live and attend at least one physical workshop. I thank IAB for this initiative and giving me the opportunity today to host this seventh important webinar, which is going to be on bronchoscopy in special situations. Now, special situations is a very broad term. There are too many questions, and for that, I have a big star-studded faculty to make my job easier. Before we start, I would first like to thank all our panelists and all the speaker to be on board and the Olympus team and the Mankind team for helping us out with all the webinars. First, I would like to introduce our speaker of the day, Dr. Pratibha Gogia. Can I have a slide, please? Ma'am needs no introduction. Ma'am is a senior pulmonologist and an interventional pulmonologist practicing in New Delhi. She's had oration recent in BronchoCon also, and she is known for her academics and her clinical work. And no better person to talk about bronchoscopic intubation step by step rather than Pratibha ma'am. So, ma'am, please take over.
Uh, Thank you for very kind words, Mehul. And I would try. I will try my best to make this topic interesting. And I think next 20 minutes I'll be doing that. And this topic is very close to my heart because I am a perfectionist and I rarely think that I do something very good. But in this particular topic, in several situations, I have felt happy because I could do, a tough, tricky intubation easy for my surgeons, for my colleagues, and in the intensive care setting. So without much ado, I start my presentation. So, bronchoscopic intubation, when and how? There are special scenarios where we choose to intubate a patient bronchoscopically. So, my first question to our, young colleagues, which patients are best suited for bronchoscopic intubation? So, where we anticipate difficult airway. It can be an emergency situation that your colleague is trying to intubate with a laryngoscope and not able to intubate, and a non-emergency situation. As we get a planned bronchoscopic intubation in OT, when we see a patient having a Mallampati score of a very high Mallampati score of 3 or 4. A patient has a pyriform fossa tumor. A patient has laryngeal radiation or surgery done. And anatomy of the larynx and pharynx is distorted. So you should be preemptively prepared that tomorrow we are going to have a surgery on such patient and I might not be able to intubate the patient laryngoscopically. So you should be ready with a bronchoscopic intubation. Another prerequisite is that there is adequate time to anesthetize with topical agents. It should not be an acute or an emergency or, a crash intubation. Then it becomes a bit difficult and tricky. The patient should be cooperative and should be able to understand the planned procedure. If the patient is hypotensive, he is unable to lie down. In that cases also, at several times in patients with acute lung injury and impending ARDS or moderately severe ARDS, I have talked to them and have done bronchoscopic intubation in the critical care settings. So these are very simple indications. I have tried to simplify the indication for bronchoscopic intubation. We need to take a consent. The consent is slightly different. We need to tell the patient that you will be awake or you will be mildly sedated. You have to cooperate. It is an important part of my job is to look after your breathing. And in this particular procedure, you'll be knocked down after we put the tube into your, trachea or into your breathing pipe. So we have to explain the things to the patient if he's educated enough or understanding enough, or otherwise to the family in case the situations gives us an opportunity. In case it is an emergency intubation or a failed laryngoscopic indication, in that way we have already taken a consent for intubation, and that can work for bronchoscopic or awake intubation as well. How do you prepare for it? We have to have a secure IV line. We need to have a monitor, minimum showing the pulse, the ECG, and the blood pressure. The patient need to be oxygenated by nasal prongs with oxygen catheter into opposite nostril or via the working channel of the bronchoscope. So these are the three main important preparations which must be done by the operator. And these are the minimum preparation, because at times you are in an emergency situation and not able to prepare other things. Then comes the very 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 important aspect: what orifice will you choose? Will you choose nose or will you choose a mouth? So, what are the advantages of a oral intubation? It may be better tolerated, no need of anesthetize the nasal passages. We can put a larger ET tube. It is a shorter route, possibly more acceptable for post-operative care in the ICU. Nasal allows surgical access to the oral cavity, possible in patients with very limited or no mouth opening. Better choice if gag reflex persists despite best topicalization. And after entering nasopharynx, the glottis is usually very much visible. So the pathway is more clear. What are the disadvantages of a oral intubation? Less direct pathway, sharp angle from the oral cavity into the larynx, easy to stray from midline. Usually, the tip of the bronchoscope at times is lost among the teeth if the patient is not very cooperative or moving a lot. Disadvantages of a nasal intubation is that passage through the nose is usually the most difficult part of the procedure and least well tolerated. Patient's nose is very sensitive, so we need to have a good topical anesthesia. ET size has a limitation. We cannot put a 8.5 or 9 ET tube. Potential for epistaxis and potential for bacteremia or sinusitis if the tube has to put for a longer time. And this is our first step, and but that is the most important step is topical anesthesia. Steady trickling of lidocaine into the posterior portion of the mouth while the tongue is manually pulled forward. So this is the first step. Some people go for transtracheal injections, which personally I'm not very fond of, and they inject lidocaine via the cricothyroid membrane using a cannula. It can pain later, and it is not recommended by any of the guidelines. Spray as you go via the working channel of the bronchoscope, and through the working port of the scope, and we can keep on delivering at the epiglottis, vocal cord, and then the subglottic area where various nerves blocks are also used, but not all anesthetists or the support staff in trained into nerve blocks. So my depend on thing is to give anesthesia or spray lignocaine as I go ahead into the airway passage. What are the sedatives? So we need not knock out the patient. We need not take help of muscle relaxants at all, but we need to give sedatives to make the patient comfortable, cooperative. We need to give allay his anxiety. We need to produce amnesia so he does not remember the very unpleasant process. Attenuated airway reflexes or antitussive, it also decreases the cough and make our procedure easy. Stable hemodynamics, if patient does not fight, he is relaxed, the hemodynamics remain stable, and maintenance of a patent airway with spontaneous ventilation. This is the most important point in my experience. Why we don't use muscle relaxant? Because we want the airways not to collapse. We want a spontaneously breathing patient with maintenance of a patent airway. As soon as you give muscle relaxants, the airway will collapse and your bronchoscope will not be able to find its way ahead, and you will be hitting the walls again and again. So the available agents are benzodiazepine, usually midazolam, propofol, alpha-2 agonists such as dexmedetomidine, opioids, and ketamine. I'll not go in details. The anesthetists know better than me. You guys know about it. So we can use dexmedetomidine. The adverse effect are hypotension. So I am not a big fan of dexmedetomidine, but we can definitely use in sub advised doses. We usually use in half in the doses because at times it causes hypotension in my practice. But it is a good agent because it causes minimum respiratory depression and no need for additional anti-silagogues. So it decreases secretion also. Then we have ketamine, a patient, if an asthmatic, a COPD patient with obstructive airway disease, ketamine is our agent of choice. It's a short-acting agent. It causes analgesia and sedation, but at times it causes hallucination and excessive secretions. Third is a new agent, remifentanil. Personally, I have no experience with this, but my anesthetist team, whenever they are there, they use it with much, comfort and appreciation. And it is a new kid on the block, so we can try this as well. Midazolam is an age-old 1 to 5 milligram depending upon the respiratory status of the patient, weight of the patient, and patient tolerates it well. Sometimes hypotension does happen. So if we choose nasal intubation via through the bronchoscope, so we put inserting the ETT into the nose, use a well lubricated ETT, use topical vasoconstrictor to nasal mucosa. Some people use xylometazoline. We insert it at the right angle and we pass it along the floor of the nose to the nasopharynx, and through that ET tube we put the bronchoscope. But I am not, this is just a way some people do it. Usually anesthetists do it, that they put an ET tube first perpendicular to the nose and later on put the bronchoscope through it, which acts as a bookie, and on the bronchoscope they load the ET tube. We can talk about it later. So let's go about a typical or a bronchoscopic intubation. I have divided into the procedure into 10-step module so that you can imbibe it or you can learn it more easily. So I'll take you in the journey step by step. Step 1, we position the patient and the monitor. I hope my screen is fully visible.
Yes, ma'am, it's visible.
So the first position is patient sitting at least 40-degree upright and facing the operator, monitor on the patient's left. So we are facing the patient. Second is patient supine with the operator in normal intubating position, monitor on the patient's right. So these are the two positions we can choose as per our expertise in bronchoscopy. In England, most of the bronchoscopies are done from the front. So they are used to doing the intubation from the front. In India and USA, we do the bronchoscopies from the back. So we can take that position. But in ICU setting, when patient is hypoxic, sometimes they are very dyspneic and they are unable to lie down. In that cases, I prefer to take a sitting and front position, but you need to practice it because if you are used to bronchoscope from behind, this might not be easy for you. I'm sorry. It's not going further.
Ma'am, you can click on your PPT again, it will start moving.
I am not able. Okay. Yeah. Then this is step 2. Railroad the chosen ATT into the bronchoscope and secure it with a tape. I hope you can see the ET tube which has been tied with a tape on the bronchoscope. So this is our second step. This is our step 3. Hold the bronchoscope in your left hand using your thumb to manipulate the lever. Suctioning can be performed with the index finger. The right hand should be close to the nose or mouth, ensuring that the insertion cord is straight at all times. And these are for a right-handed operator. So can you see the position in which we take the scope to the patient? Step 4 and 5. Orient the scope to ensure that the image is being correctly displayed. So once you are inside the patient's nostril or oral cavity, you have to take minimum time. So you have to you have to check the image, you have to check the white balancing and focusing has been performed. You have had an anti-fog spray has been applied to the tip of the scope. And for an oral intubation, place the oral intubating device in the mouth. Otherwise, your patient will chew your scope. I hope I'm clear on these parts. So these steps are to be done before inserting the bronchoscope in patient's nostril or into the oral cavity. And this is step 6. Insert the bronchoscope into the nose or oral intubating device and follow the patient's passage until the epiglottis comes into view. Identify the vocal cords. So this is the step 6. So we have to see that the tip of the bronchoscope just witness epiglottis, and we pass it below the epiglottis and identify the vocal cords. We have to try to keep the scope in the midline all the time. And now step 7 and 8, maintain vocal cords in the center field of view, advance the bronchoscope in the mid trachea and firmly hold it in position. So our scope, tip of the scope is now into the trachea. And now we have to hold it firmly there. We can take help of our assistant. And now comes step 9 and 10, which are the final step. Insert the ET into the nose or oral airway and advance the ET over the bronchoscope into the trachea. Position the tip of the ET 3 to 4 centimeter above the carina using the bronchoscope. Touch the carina with the bronchoscope, withdraw to the end of the ET and measure the distance. Confirm position of the ET using capnography before inducing general anesthesia. I'll be showing you a video to this thing. So this is how you railroad the ET tube on the bronchoscope. Now I'll fix it with a tube so that it does not become loose. Look at it. And now I'm holding the scope into my left hand. I'm ready. We are going for a nasal intubation in this patient. Oxygen is there. We are removing the nasal cannula to one nostril because we will be using the right nostril for bronchoscopic intubation. So there are two approaches, ET first or bronchoscope first. I introduced this topic before. So some people just put the ET into the nose after lubricating it, and through the ET they put the scope. And as I do, I put the bronchoscope first. Less risk of bleeding prior to entering the trachea, because when we put ET blindly, sometimes the nasal mucosa can bleed and the field of vision becomes totally bloody or blurred. Though anesthetists are more comfortable with ET first approach because it minimizes the time to advance ET into the larynx. And it is a blind insertion, may produce bleeding, rendering bronchoscopy very difficult. Blind passage into the nasopharynx may damage the mucosa. And if we put the bronchoscope first, ET can be difficult to advance over the Sometimes ET always, the tip of the ET tube, it gets entangled into the piriform fossa, and we have to rotate it anti-clockwise to bring it at the level of vocal cords. Bronchoscope can pass through Murphy eyes, which will make advancement impossible. So these are the advantages and disadvantages of two approaches. So this is another video to make things clear. So my operator, my assistant is giving me local anesthesia. We are monitoring the vitals. Look, tip of the bronchoscope is now at the level of the vocal cords. I'm trying to keep it in the center. Patient is coughing. I have passed the vocal cords. I have gone to the mid trachea. Now my assistant will disentangle the ET tube. I can't do it myself, so nurse is doing it. This is a real life situation. And now I'm railroading the ET tube over the bronchoscope. I feel some resistance, so I will bring the tip of the bronchoscope up, out. So look at it. I bring it to the vocal cords, and with the ET tube and under vision, we have again to the middle of the trachea. We have checked the position of the tip of the ET tube. So what difficulties we can find while doing this procedure? Reduced airspace passage due to sedation, edema, or obesity. Supraglottic mass could be there. Distorted anatomy or deviated larynx could be there. Vision obscured by blood or secretions. Red out. Scope is likely to be in the pyriform fossa or esophagus or impacted on mucosa. What are the remedies for the beginners? Ask patient to protrude the tongue or phonate. Tell patient to say something or say ah, or tell him to take out his tongue or breathe deeply. Retract the tongue by an assistant holding it between a folded gauze. So sometimes the vision is obscured by the tongue of the patient. So your assistant can hold the tongue with the gauze piece. Use an oral intubating device. Along with the bronchoscope, we have intubating laryngoscopes, or the anesthetist can give you a guidance by using a laryngoscope. Ensure that it is midline and withdraw slightly. Get assistant to perform gentle jaw thrust. You can see that how to perform the gentle jaw thrust or tilt chin lift maneuver. This elevates the tongue and epiglottis away from the posterior pharyngeal wall and opens the path. Suction any blood or secretion with the bronchoscope or a Yanker's suction. If you have difficulty advancing the ET over the bronchoscope, as happened in the video I shown you, the ETT can get caught while passing through the vocal cords, often on the right arytenoid. Left facing bevel results in the tip of the ET impinging on the right arytenoid. Deviation of the ET from the bronchoscope due to the gap between the two. When performing a nasal intubation, ET can become impinged on the epiglottis. So these are the difficulties when the face. How to handle it? Rotate ET 90-degree clockwise, bevel up if the site of the impingement is the epiglottis. Use a video laryngoscope or in addition to the bronchoscope to assist with visualizing where the ET is impinging. Rather than using a big size ET, use a smaller size ET tube. It will be easier for you to intubate the patient. So these are few tips. Keep the target structure in the center of the screen. Small efficient movements of the brow. Don't take big leaps. Go very slowly. The operator should be comfortable. Arm fatigue is common if the scope is being held too high or either too low the bed or stand on a step to allow the scope to hang freely. If your height is short, if the this thing, take a stool. Ask the patient to take a deep breath and synchronize advancement of the ET with vocal cord abduction. A small piece of tape applied to ET will prevent it from dropping. Warm the ET with warm water to soften the tube and reduce fogging. Tips to prevent fogging: use an anti-fog solution on the tip. Apply 2 liters of per minute of oxygen through the working channel of the scope. Sometimes we put, so like a esophagoscope, the oxygen keeps the vision clear. You can do that. This is a trick I have developed on my own. And this is again a video. I'll see if this works. It's not working. So it was a nasal intubation video from the front, but I think there is some problem. Let me see if work. No, it's not working. I'm sorry. So I think if I able to get that video again, I'll show it. Meanwhile, the panel discussion goes on. So these are the few references, and it's a very satisfying procedure, bronchoscopic intubation, because most of the time patients larynx is on the left side, right side, there are big tumors, and it seems almost impossible to intubate that patient, and he's very nicely intubated in a sedated awake situation. Thank you so much. Thank you for the patient hearing.
Thank you, ma'am. I mean, it was really a step by step. You gave all the details, an excellent lecture. Actually, this shows your passion for this kind of topic. I mean, you could show us step by step in writing and then the videos also. In fact, like for people doing it on a daily basis, also, you will pick up a thing or two when you listen to such lectures. Thank you, ma'am. An excellent lecture. And keeping that tone in mind, now we'll move to the panel discussion. Now, this is a very broad topic, so I've tried to cover as much ground as possible, and we have a star-studded faculty to help you navigate through these special situations. These special situations can be different for you, may not be the exact ones that we discussed, but we'll try to accommodate as many as possible. So to start with, I'll introduce my faculty. My first panelist is our senior, Dr. P.S. Thampi sir. Sir needs no introduction. Sir is a senior DM pulmonologist. He's the honorary chest physician to the governor of Maharashtra. He's look at the accolades. I mean, sir has. I mean, if I keep on reading it, I'll just finish the webinar in this. Sir is currently a senior consultant pulmonologist and physician at Bombay Hospital. Sir has been a guide for IAB for so long. He has been guiding us all throughout. He did receive a Lifetime Achievement Award from Award Medical Association in this year and was felicitated with Thoracoscopic Endoscopic Society Oration Award for 2025. Welcome, sir, for this webinar.
Thank you. Hi.
Next panelist is my senior from Jaipur, Dr. Shubhra Jain. She is the professor and head of department at SMS Medical College, Jaipur. She has got Rajcon 2008 Hans Kumar Memorial Award and NAPCON 2015 Best Research Paper and the T.N. Sharma Oration Award for 2025. She is a textbook. Please listen to her. Next, we have dynamic Dr. Abhishek Tandon. He is the he's the consultant and in charge of division of Asthma and Allergy Department of Respiratory Sleep Medicine at Medanta, Lucknow. He has more than 32 publications and 2 book chapters. He also runs the IAB IP Fellowship under his wing. And I mean, you just need to see his experience when we come to the panel. Welcome. Next. We have Dr. Vishal Chitikeshi. He's a senior consultant, interventional pulmonologist, and lead consultant for IP services at KIMS Hospital, Secunderabad. He has established the IP program in 2 corpus hospitals and currently also is having the IB IP fellowship. And he has more than 10 years of experience in the interventional pulmonology, and his key interests are IP, allergy, asthma, and pulmonary rehabilitation.
Thank you.
Yeah.
Now it's my proud privilege to introduce the moderator for today, Dr. Mehul Thakkar, who actually needs no introduction. He is a very dynamic and effective secretary of the last conference we had, the Thoracic Endoscopic Society in Bombay, and all of you know him very well. He has over 15 years of experience. He is a former assistant professor at KEM Mumbai and LPMC Sion. He's trained at interventional bronchoscopy in Cape Town under the late Professor C.T. Bolliger. He is the honorary treasurer of the Indian Association of Bronchology, organizing secretary of the TESCON 2025 Mumbai, which was a hugely attended conference. And he is a consultant pulmonologist at the moment at Jupiter Hospital, Thane, and Fortis Hospital, Mulund. He has numerous publications in both national and international journals. He is the director of Medansh Multi-Speciality Hospital at Mumbai. So over to you, Dr. Mehul.
Thank you, sir. Thank you for the kind introduction, and we'll jump right into it. We have too much ground to cover. So the first question comes to you, Thampi, sir. Now, what is the standard? But we had the talk. Now we'll be having the one-on-one discussion. These are the questions people get when they are dealing with the situation and with the patient in front of you. So, what is the standard pre-procedure airway assessment that you do for a patient undergoing a bronchoscopic guided intubation, particularly if you are anticipating a difficult airway? Sir, you are muted, sir. Sir, you're muted.
Sorry. Yeah, it's a problem that we come across often in our practice. And we are faced with this issue about intubating this patient, and often the anesthetist seeks our help. And so how do we assess that the airway is difficult? Well, there is a simple mnemonic which we refer to, the lemons, LEMEONS. It's a simple way of remembering this mnemonic. So what is L? L stands for look externally and observe for short, thick neck, prominent teeth, a large tongue, facial trauma, beard, or obesity. Okay. And then we go on to lemons, LE. So E is basically evaluate. How do we evaluate and what do we evaluate? So simple, using the 3-3-2 rule. 3-3-2 rule. 3 finger breadths for opening the mouth. That means you want to assess the inter-incisor distance by putting 3 fingers like that in the mouth, right? So that gives you, if you can open your mouth and allow 3 of your fingers to go inside between the incisors, upper and lower incisors, you have an adequate opening for intubation, right? And bronchoscopy. Now, the next 3 is for measuring the distance from the hyoid bone to the chin, which is known as the hyomental distance, this distance. Now, if you have a jaw which is pushed back, you obviously have a very short area, and it may be very difficult to intubate in such patients. And the last 3-3-2, the 2 actually measures the finger breadth from the thyroid notch to the floor of the mouth. Now that gives you the distance that you need to cover. Then, of course, coming on to, now we have covered L, E, and coming on to M. M is something that we are all familiar with, the Malampati score, which is from 1 to 4. And you know that it involves the soft palate, the uvula, the tonsillar pillars, right? And we all, being experts in obstructive sleep apnea, all of us know how we grade this between 1, 2, 3, and 4. 3 and 4 category may fall into the difficult airway category. So you need to be careful and you need to prepare yourself for such kind of an eventuality. The O, the lemon, LEMO. O stands for obstruction. Look for signs for masses, tumors, swelling, blood clot, foreign bodies, etc. Stridor is a key indicator of upper airway obstruction. So you must remember this, look for it, right? And then you come to the most important and the last, the LEMON. N is for the neck mobility. Assess the ability to move the neck into the sniffing position. That's the neck flexion and head extension. Okay. So if you can do that, limited mobility due to arthritis or due to a fracture or trauma can impair your intubation process. And having assessed all these factors, then you must be prepared to do the intubation either through the nose or through the mouth, as was very nicely shown by the speaker, Dr. Gogia.
Yeah, thank you, sir. So it's very simple clinical tips that Dr. Tampi has given, and take your time to assess the patient. Don't rush into it. Look at every possible thing which can obstruct you and be prepared for the worst case scenario. And also sometimes it is better, like you can pre-oxygenate the patient while things are getting prepared. So the next question comes to you, Dr. Shubhra. What are the indications and contraindications while when you're choosing a bronchoscopic guided technique for intubation?
So let's talk first about indication. So one is obviously the trauma to face or upper airways, or when there is cervical spine injury, fracture is there, or patient is having congenital airway abnormalities. Then another is if a patient is having history of previous difficult intubation, then that also becomes an indication. And the most important is if a patient is having presence of anticipated difficult intubation. So from here we look at, like, patient is having restricted mouth opening, patient is having trismus, or patient is having receding mandible. These are the indication. Patient is having a large tongue, or patient is having tumor of adenoids, tonsils, laryngeal mass, or mediastinal mass, like large goiter. sometimes there is fixed flexion deformity of neck that is seen usually in cases of sometimes burns. So then also this tool becomes very essential. Then another important thing is DNI. This is what is used like deep neck infections, which all like retropharyngeal abscesses, oropharyngeal abscesses, which obscure usual laryngoscopic intubation. And then, as ma'am told, sometimes in critically ill patient, this is also important modality. Now, coming to contraindications, most important contraindication when patient refusal. Most and another are like patient is uncooperative, patient is mentally not fit. Then always take the history of intracranial hypertension. If it is there, then if a patient coughs, then it may precipitate intracranial pressure. If a patient is having history of basal and skull fracture, then if we nasally intubate that patient, then tube can slip into the skull. So it is ideally it should be avoided. Then there is history of bleeding diathesis, like it can increase the risk of epistaxis, so we can change our route from nasal to oral. So this is one of the relative contraindication. Another is when there is grossly distorted anatomy, like you are not even able to visualize the glottis. So this can also be this is again a contraindication. Then if a patient is having vomitus or excessive secretion in airways and we are not able to visualize the airways. So these are almost all contraindication I think I have covered.
Yeah, ma'am. I mean, so all the relative contraindications for a bronchoscopy procedure, plus the things that ma'am said, all combined. Um, be aware of the patient that you're doing. Assess the patient 1 day prior. That should be the best thing to do before you decide whether you want to go for a bronchoscopic intubation or no. Now, let's say we choose bronchoscopic intubation, Dr. Abhishek. What are the anesthesia considerations for such patients, local and systemic? Like ma'am has already mentioned, Pratibha ma'am, about thing. But if I have to ask you a point blank, I mean, what anesthesia considerations would you keep in mind?
So, like we've been discussing for a very long time, bronchoscopic guided intubation is generally done for patients who either have an anticipated difficult airway or in which intubation is being tried and on spot the anesthetist decides that it is a difficult airway. So muscle relaxant is one thing that I would definitely don't want my patients to be subjected to, because once a muscle relaxant is administered, the airways collapse and then you go into a conundrum. As far as sedation is concerned, what we generally do in our practice is a mild benzodiazepine generally does the trick. It sedates the patient and gives us ample time to do the procedure very carefully. And we generally do it under a multimodality approach. So we have an anesthetist on our side who does administer the anesthesia, and we take care of the intubation part of it. But yeah, to answer your question, a mild benzodiazepine is something that I'm very comfortable with, and I'll definitely just go with that.
Agreed. You should be friends with the anesthetist, because if there is no coordination, you can land up in trouble. I've had 2 cases where they just push propofol even before I could reach the vocal cord, and then you can land up in trouble. So the coordination between you and the anesthetist has to be spot on. Provided, I mean, you've got enough time to discuss. This case was an emergency, anesthetist was also rushing, all those things were happening, but still, giving benzodiazepines, as you said, is the best thing. Topical anesthesia, as ma'am, Pratibha ma'am showed, giving a 10% spray helps. Giving the local jelly helps if you're going nasally. So local anesthesia, yes. Midazolam, yes. Muscle relaxant, strict no unless you have crossed the vocal cord. So this is what you need to remember. Now, let's say you've now figured out the anesthesia, you've figured out the indications, contraindications. Dr. Vishal, what special equipment is crucial? I mean, you do it like a normal bronchoscope, or you just require a crucial, some extra equipments? And one more thing, what appropriate size of ET tube will you choose?
Yeah, so my way is usually to do from behind the patient. The
Mm,
special equipment which I use is a bite block.
mm.
Preferentially, I do trans-oral intubation and under anesthesia. I mean, I prefer a little deeper plane, but the I make sure that the muzzle relaxant is not given and the vein mask ventilation is possible. Just like how we place a eye gel or pre-oxygenate before rigid intubation, the anesthetist should be confident enough to come back to the bane mask and again give some time for intubation. So the size of the scope, the difference between the ET tube and the bronchoscope preferentially should be 1 to 2 mm, not beyond 2 mm, because the lesser the space, the easy the railroading can be done over the bronchoscope. And the key thing which I use is a lot of gel for lubrication inside and outside. And the rotatory movement, like clockwise and anti-clockwise, is what really helps to pass it very easily. The special equipments, especially pre-oxygenation with the anesthesia team. But if high flow nasal cannula is another equipment which can be preferred to maintain higher SpO2 or higher PO2 levels. Just that gives a time for your intubation. And once it's done, definitely go for general anesthesia. Yeah.
Yeah, well said, well said. So to keep it very simple, if you're having an adult bronchoscope, the standard size 7.5 is the tube, which you will probably prefer. By may not go nasally, so as you said, oral route might be preferred in such patients. If you have a
Yes.
smaller bronchoscope, then yes, probably you can put a smaller tube, you can go nasally. But
Yes.
always keep the resuscitation. You will probably be in an OT or in an ICU, so always keep the resuscitation equipment. One thing which has helped nowadays, or at least for me, I've told my anesthetist to keep a video laryngoscope standby. Sometimes it might be difficult, so a video laryngoscope might help guide you. Sometimes it might be difficult to put it nasally also. So this is what you need to remember.
Mehul,
Suctioning should
I
be,
want to add one thing.
yeah, ma'am.
You should be ready with an LMA, an adult
Yes.
LMA.
Yeah.
In
So that's,
case of failed attempt, at least an adult LMA can give some seal, and in case of emergency like bleeding, losing the airway, you know,
yeah, so that
something in
is very important.
LMA.
Dr. Vishal mentioned IGEL, that is the
Right,
LMA that he was talking about. So
right,
that
right.
is what you need to have. LMA, see, your anesthetist has already prepared for the worst case scenario, and that's why he has called you. You should be prepared, and the anesthetist should have all the tray ready. You may not use it, but everything should be available at your disposal. Correctly said, ma'am.
Yeah.
Now, uh, yeah, coming to the next question, Tampi sir. If I am going to choose a bronchoscopic guided intubation, what would be the difference between a nasal and an oral approach? Ma'am has already said, but can you summarize it a bit?
Yeah. See, most of us would prefer to use the nasal route for bronchoscopy, which we usually do, and therefore uh, I would prefer that. But however, in the case of using a larger endotracheal tube, you probably would prefer the oral route. The advantages of using a nasal bronchoscope is that you can use a thinner scope, and there is less chances of bleeding, like epistaxis, etc., less damage to the nasal mucosa when you are putting the endotracheal tube, railroading it over your bronchoscope. And there is a less chance of a gag reflex because the tube, when it goes along the curve into the trachea, into the larynx and then into the trachea. However, let's not forget that there could be epistaxis and bleeding when you use the nasal route. Whereas the oral route, probably less bleeding risk is there, and you can use it for larger size endotracheal tubes, and it is faster to intubate through the vocal cord in some studies and avoids nasal issues altogether. However, there is the danger of a gag reflex, which being activated if you use the oral route. So that is something that we need to do. And also you need to prevent scope damage when you're using the oral route. So a bite block is mandatory in these patients.
Yeah, thank you, sir. So it depends on which route you are comfortable with. Tampi sir spoke about being comfortable with the nasal route. I mean, sir, if I may, I also behave like an old timer. Nasal route is preferred, but all new people prefer oral route for some reason. I don't know, even for normal routine bronchoscopies. So that's okay. It's a personal choice. There's no win situation, win-win in any of these things. But when you're choosing, choose the route which you are comfortable with. That is the first rule. Second rule, I mean, look at the airway, whether you can actually go orally or not. If the surgery is going to be an oral surgery, the nasal route has to be taken. And look out for bleeding. Don't push. If you push and if you suction during the nasal intubation, most important is don't suction when you're in the nasal cavity. You'll definitely cause a big bleed and it'll mess up the whole field and you'll not be able to intubate it. So choose the route wisely. And if the nasal fails, please go orally. Very well said, sir. Dr. Shubhra, now let's say you have decided and you're trying to put a bronchoscope, you tried nasally, orally, and you're finding resistance. So what techniques can one use to facilitate the ET tube passage smoothly?
So the first and important thing, as Dr. Vishal also mentioned, that adequately lubricate. It is not only the endotracheal tube, but also the tip of shaft of bronchoscope that also should be fully lubricated. Then second thing, one commonly encountered thing that usually ET tube goes into right arytenoid cartilage. This there it get caught up. So just you have to rotate counterclockwise and 90-degree, and then you can align with glottis. Another important thing, this is also mentioned by ma'am in his lecture, that you can warm the endotracheal tube. It has PVC material. It is made up of PVC material, so it makes it little easy to maneuver. However, the temperature you should be around 40-degree, and you have to warm it for 10 minutes. Excessive warming may cause, in fact, kinking, over kinking can be caused. So,
Yes.
and if we all doing this and still we are not able to visualize the glottis opening, then what we can do, ELM, that is external laryngeal maneuver. One is anterior jaw thrust. Another is, which we usually also do while doing intubation, we press our hand interiorly on the neck, and just we move it like press it downward. So sometimes visualization become easier. So these are the things which we can do. And sometimes oral, there is difficulty while doing this with oral route. So we can also use some special airways so that that scope can be kept in midline.
Yeah.
And there are special AIN catheters are also available, which can help. These are There are very good videos available in that, and these catheters can also help when there is difficulty in going the endotracheal tubes.
Yeah, and as you very well said, and then sometimes you do get stuck still, and then there the video laryngoscope which I spoke about helps. So having,
Yes,
if
yes.
you have the facility, I mean these, please understand when we are talking about, you may not be having all these things at your disposal, so you'll have to use whatever is available. But you should know what all can be used in such situations. You can also use a Magel's forceps sometimes to push the endotracheal tube down, but these things should be available. So please be aware of what is to be done ideally, what all can be used, and whatever is there at your disposal in an emergency. Very well said, ma'am. Coming to the next question. Dr. Abhishek, what are the most common complications that you face during this bronchoscopy guided intubation, and can you give some tips on how to manage them?
So coming back to where we left the last time, it's again mostly when you do a bronchoscopic guided intubation, it's either for a anticipated difficult airway or a difficult airway which comes in an emergency setting. So the most common complication which I generally encounter is hypoxemia. And to encounter it, we need to ensure that even in case of an emergency setting, we need to keep our cool, be there with the anesthetist, ask him to pre-oxygenate the patient adequately so that you have an ample time to intubate the patient. We should not rush into the procedure. Rushing has resulted in injuries both to the patient and to the scope. So we need to again maintain our calm, navigate step by step as shown by Dr. Gogia brilliantly in her presentation, ensuring that the trauma is not caused to any part of the upper respiratory tract. And if we do that, that is something that can also be prevented. Also, a very common mistake which is done and which has also been spoken about is the administration of muscle relaxant before passing the vocal cord, which causes the upper airway collapse, and you don't have anything. We have encountered such a case where we had to resort to an emergency tracheostomy. So choose the sedatives that you are going to administer while performing a procedure adequately. So I think these are the frequently commonly encountered complications for a bronchoscopist while attempting an intubation, and the measures to mitigate them.
Yeah, very well said. In fact, the more procedures you do, the more such things you see, giving the muscle relaxant, where we say don't give, don't give, don't give. Sometimes it still happens, and as you said, even one of my patients had to go on tracheostomy because overzealous administration even before you could enter the vocal cords. So let's say now you've tried everything, Dr. Vishal,
Yeah.
and the awake intubation has failed. What would you do? What is your best strategy then?
So as I mentioned, um, this situation doesn't come if the bronchoscopist is perfect with their basics, like choosing the right ET with the right bronchoscope, adequate lubrication, staying in the center, jaw thrust, which ma'am has covered, and the technique to maneuver near the vocal cord. Usually, this does not happen. And I would say if awake intubation still has failed, take your time, come back, pre oxygenate, put the igel, and try to do again. I mean, I'm not understanding why this awake thing may fail. If the patient is resisting only, it may fail. So usually my way of doing it is propofol. As some of the speakers mentioned, mild. I mean, they prefer to do it in the mild sedation. I would deepen the plane of the anesthesia and would try again a bronchoscopy. If I fail through trans oral route, I will go through trans oral route. So if a failed awake intubation happened, then that means that the failed bronchoscopy also for the same patient. So I'm not really convinced why awake intubation may fail, and if any other speakers may add any points.
Yeah, ma'am. Pratima, you want to add something?
Once I was intubating a very young child. He was breathing at a rate of 40 per minute. It was, difficult to pass the tube. I was standing on the vocal cord, unable to pass the tube. Had to change, a tube from the side of the bronchoscope with the help of a laryngoscope. Or if you are on a very bigger tube, as Dr. Chitkeshi said, you come back, bag and mask, your patient is awake. So bag and mask your patient if you don't have anything, and take a second attempt with a thinner tube, with a softer tube, with more lubrication, with better form of anesthesia, and call for help. Your anesthetists these days have very beautiful intubating laryngoscope, ENT surgeons. So means that's how, if you have failed bronchoscopic intubation, means it's a real challenging scenario. So you need to collect the whole village then.
Dr. Mehul, I just want to just another tip for the audience here. I don't hesitate to use a complete tube of gel for lubrication. I mean,
Yeah.
when I go for this intubation, they tell from inside I'll put lot of gel from top to bottom, but from outside you have to make sure you're not lubricating the upper part of the ET tube,
Tube.
because the person who is holding the tube
I'm
should not
pushing it.
have lubrication
Hmm.
from outside. So the tip at the 10 centimeter at least you have to put lot of gel. And if you reduce the diameter between the ET and the bronchoscope, the railroading is so good.
So
The
easy.
bigger the bronchoscope, the best is the uh, railroading. If you want a six tube, now you have all the IP units have 5 mm, 4.2 mm. For each diameter, we have a bronchoscope facility for fiber optic intubations. So I would really say if you stick to the basics and apply your basics and lubrication and choice of ET tube, it is definitely a success.
Dr. Chitkeshi, I would like to disagree.
Yeah.
Number one. Number two, one bronchoscope is good enough. So any size bronchoscope is okay, thin or thick. ET tube should be moving freely on the bronchoscope. Even if
Yeah.
you have a thinner bronchoscope, sometimes it's easy to pass the vocal cords. Just don't go too close to the carina. Just be in the middle or close to the vocal cords, and try to very in baby steps push the ET tube, because now you are at the tip of the pyramid. If you fail, it's a real emergency. Either you are doing a tracheostomy, either you are doing alternative way of ventilation. So I do not want the residents to take the message that you need various size of bronchoscope. Any size of bronchoscope is okay with the tube which is mobile on that bronchoscope. If you
No,
have
ma'am. I
open
mean to
tube, it is
say, if
okay.
you want to put a 6 mm or 5.5 ET tube, but you cannot use the adult bronchoscope.
No, that's true, but
Yeah.
that's what I'm
So
saying. Then you have to
let
take a
let
7.5 ET tube only.
let me put it this way. These are going into very big nuances. I mean, most of us, like in private practice, probably would have a one bronchoscope. If you are in an institute, probably you would
Yeah,
have a buffet of
buffet
equipments
of
in front of you.
bronchoscopes. Yes,
So, but for general consensus, if you have a single size bronchoscope which you have been using it, you know what kind of ET tube fits on it. And
yes.
if you're working in an institute, like I go to Jupiter Hospital or Fortis Hospital, I know this is the size of bronchoscope available. So this is the size of ET tube I can push. And as Dr. Vishal said, if your awake intubation fails, it's a big problem because you are the last resort. If you are failing, then probably you should abandon the procedure or delay the procedure or maybe call for more help. I think we have a lot of ground to cover, so let's move on, ma'am. Dr. Pratibha, ma'am, I'm coming to you now. Now let's move on to other special situations. There are a lot many situations which can be special. So what precautions will you take for a patient for bronchoscopy who had a recent arrhythmia?
It should be very fast, number one. You should not be very taking very long. So you're the best bronchoscopist should be doing the procedure. That's the first trick. Second, maintaining oxygen. Hypoxia is the best, is the most common trigger for arrhythmias. Third is the support of a cardiologist. So sometimes they are, most of the times, they are unprecedented. You have not just thought about it that the patient will go into arrhythmias. So if patient has an arrhythmia, intubation goes side on side with maintaining the saturation. I do not will be not concentrating on intubating the patient. I'll just keep it at the back of my mind and try to maintain the oxygen by all possible measures, identify the rhythm, try to correct the rhythm if medically possible, and at the same time will prepare a mental plan to intubate the patient so that after 5-10 minutes we have a secure airway. So that is my approach when I have a patient who develops arrhythmia on table. If the patient is a cardiac patient, we have this thing, we take cardiac clearance, we try to stabilize the patient. If patient is this thing have very rhythm problem, a TPI or things like that, but they go much before the actual procedure. I'm talking about on the table. If arrhythmic patient is there, do not concentrate on putting the tube. Concentrate on maintaining oxygenation by any method. By any method. Sometime you put the scope, not able to railroad the tube, leave the railroad, put oxygen cannula into the scope suction channel. Oxygenate the patient, maintain the oxygenation.
Yeah. So in conclusion, what we have is if there is a patient who has developed arrhythmia during the procedure, you should be quick. If you're doing a planned procedure, if you're doing, let's say, a routine bronchoscopy. Now let's focus our next part of the panel on routine bronchoscopies, not just intubation. And we have a routine bronchoscopy patient who has an arrhythmia, who's a known case of arrhythmia. So as ma'am said, taking the cardiac consent, monitoring, making sure the arrhythmia has been reversed, and ensuring the procedure is quick with the least hypoxia possible. That is the best way to do it. Thank you, ma'am. Now, Tampi sir, asking you, this is for a routine patient for a bronchoscopy. Now we're talking about the situations which you and me face when we get calls for bronchoscopy. A patient has got admitted with an acute coronary syndrome and you get a call for bronchoscopy. Will you do it? And if not, why and when will you do it?
Yeah, this is often encountered in our practice, and acute coronary syndrome should be respected. And as per the guidelines, one should not do an elective bronchoscopy for the next 4 to 6 weeks at least till the heart settles down. But having said that, there may be certain situations where you may have to scope the patient urgently. For example, if the patient has a foreign body and he is in respiratory distress, for example, if he has aspirated and he is in distress, or he has massive hemoptysis. Don't forget, these patients of acute coronary syndrome have been probably taken for a primary angioplasty, and they have stents in place, and they are on dual antiplatelet drugs. So one must remember this when you're doing the scopy in such a patient. Even if it is an emergency, you're going to face profuse bleeding, even with minimal trauma. So this is the message that I want to pass, that do not rush into the procedure, number one. Number two, is it really required? Is it really indicated? If it is possible to postpone it a little further, then it would be better because the heart would get more stable. Remember, the moment you put your scope, the heart rate goes up, the oxygen level comes down. Okay, all this has been already discussed, and therefore we don't want to put stress on the heart. That is the most important part when the patient is just coming with an acute coronary syndrome. So, having said that, when you're doing the bronchoscope also, you should be very careful to monitor the saturation, the pulse rate, the BP, etc., to make sure that you're not producing more than the minimum stress that the heart could take. But it's a very risky procedure, and I would actually try to buy time. That's being most practical.
Yeah. So the recommendations would be to wait for at least 4 to 6 weeks if you can. But as Sir said, if it's an emergency, if there's bleeding or if there's a foreign body, or if anything which requires an urgent intervention, at that point, probably you will have to go in, take high risk consent, probably do it in an ICU or an OT setting with every possible backup at your disposal, because these patients are on blood thinners, chances of arrhythmias are very high. That's why I started with the arrhythmia question. Make sure that your patient does not become hypoxic during the procedure, because these are the patients, if they become hypoxic, their things can go haywire at any time. And also keep everything ready. The resuscitation trolley, bag mask, ET tube should be ready. Now, let's say, ma'am, Shubhra ma'am, I'm talking to you. If the
Yes.
patient bronchoscopy has to be done, as I was saying, probably I stepped on a little. How will you go ahead with it? What are the procedural considerations for such patients? You have got a call, you have to do a bronchoscopy now.
Yes. So before going for bronchoscopy, we should also take a history of type of stent put in the patient. Like if it is a bare metallic stent, the rule is that you cannot stop any anti-thrombotic agent for a month. But if it is a drug-eluting stent, then you cannot stop drugs for 6 months. So this should be kept in mind. So now what you will need, one is most important thing, have a good liaison with cardiologist. We all know that these procedures are associated with increase in cardiac output, heart rate, BP. So what we can do is minimize distress to patient. We can use adequate sedation, which is easy, and we should preferably have anesthetist for these cases. And we should adequately oxygenate the patient. As ma'am said, oxygenation also increases the risk of arrhythmias in these patients also. Then we have to understand what is bridging therapy. Suppose a patient is on warfarin, then we can use either heparin or LMWH, low molecular weight heparin, for bridging. So we will stop these drugs 5 days before, and we will start either LMWH or unfractionated heparin. And before doing bronchoscopy, just stop heparin 5 to 6 hours and 24 hours LMWH. So the time to stop LMWH before bronchoscopy is 24 hours, and time to stop heparin is 6 hours. So by doing this, we can avoid the risk of bleeding, especially with these clopidogrel and warfarin agent. I also had a talk with my cardiologist friend, and she suggested that if your patient is on clopidogrel, then they are using one agent, tirofiban, as a bridging agent. And what it is actually costly, a little costly, as I'm working in government, there it is not feasible for patient to buy. But tirofiban is one agent that can be bridged instead of clopidogrel, and one can stop tirofiban just 8 hours before bronchoscopy, and so this procedure can be done.
Yeah.
Tirofiban is expensive for private setting also, Shubhra.
It costs 40,000 per day.
Yes.
Yes. So just I told you that this is
Yeah.
also we should know that this is also a choice.
Yeah, yeah. So in an ideal setting, probably in an ideal world where cost is no issue, it can be used. But most of your patients are going to be on some form of blood thinning agent, either an anticoagulant or an antiplatelet. So we need to be prepared for the worst case scenario. And as you said, make
So the
anesthetist and
best choice is LMWH, I think,
yeah,
that can be used as a bridging agent.
yeah. So if you have a stable patient, let's say Dr. Abhishek, If you have a stable patient, an ischemic heart disease, routine ischemic heart disease patient has come to you and you need to do a bronchoscopy. I'm giving you a very simple situation. Many of our patients have ischemic heart disease and you have to do a bronchoscopy for a lavage or for a biopsy. Many of these patients have low ejection fraction and they might be 25%, 30%, 40%, depending on the past history. So what are the special considerations in such patients?
So I think most of it has already been spoken about, but I'll reiterate some points. First of all, you have to be quick. You have to ensure that a minimum sedation is used. I would still subject these patients to a cardiology opinion before I undergo or take them for a bronchoscopy to ensure that their medications are optimized. And also, these patients have some problem, especially with the reduced ejection fraction, to lie down supine, so we can ensure that the bed is tilted up by an angle of 30 degrees, which makes them comfortable. And also what we routinely do in our practice after a do cardiology consultation is we don't stop clopidogrel for a routine bronchoalveolar lavage. Only and only if we are going ahead with a biopsy or a TBNA would we stop a clopidogrel or a bridge a patient to a heparin. Otherwise, if we are just subjecting a patient to a routine bronchoalveolar lavage, we don't stop any of the antiplatelet agents. And we've had a chat, we've had a multidisciplinary discussion at our institute, we've reviewed the guidelines, and I think we are fine as far as it goes. And Dr. Gogia can also pitch in, ma'am. I think the recent evidence says that we don't have to stop clopidogrel for a lavage.
Yes, we for lavage we do not stop anything. But if we are doing an EBUS, even if you are in FNAC, we stop clopidogrel for minimum 72 hours.
Yes.
Even NOACs, most of them are to be stopped for 72 hours. Bridge therapy is the answer. We stop them, put the patient on low molecular weight, stop or withhold the last dose of low molecular weight heparin and give it post procedure, 4 hours post procedure. So you're absolutely correct, Abhishek.
Yeah, thank you. So this is, see, trying to cover all possible scenarios that you might face when you're sitting in an OPD and you get a call or you're getting a reference. So we probably will have some overlap somewhere. Now, Dr. Vishal, speaking to you, in case of valve replacement, as we've all been discussing, patient has been on anticoagulants. How do you plan a bronchoscopy in such procedure, pre-procedure, intra-procedure, what all things you normally do different from a routine bronchoscopy?
So these patients are usually on NOACs or usually warfarin or acetrom. So it depends whether I'm doing a elective or an emergency. For an emergency, if the patient is on warfarin, immediately we prefer to administer vitamin K, keep FFPs ready, or even transfuse to reduce the INR and take up the procedure. But if it's an elective, as already the speakers mentioned, we stop it and wait for the INR to be less than 1.5. And this is especially, as Dr. Abhishek mentioned, if we are planning a TBNA or a TBLB procedure. But if it's for a BAL procedure, as long as the procedure is anticipated to be less bleeding, we proceed even if the patient is on warfarin on an elective basis. But if there is a plan of such thing, wait for the INR to be less than 1.5. And for NOACs, 72 hours stopping, bridging to low molecular weight heparin, and stopping 12 hours before the procedure. Especially these days, I mean, I would try my best to see the alternative options to get the diagnosis. I will try my best to postpone or prefer an alternative method to give the treatment. But if it's a situation, then I would definitely, especially for EBUS, I usually prefer going by, if there is a subcarinal node, I would do a USB FNA in such patients. So these are some of the modifications which I do in such patients to reduce the chance of bleeding. And if I have to reduce the bronchoscopy time, so normally the norm is like you look go to the normal side, check all the segments and come and go to the abnormal side. That would take at least a minute. I would just minimize it because I know that side is anyway normal. Just a quick glance and go to the problem, go to the segment, get the lavage and come out. And always the basic skills are needed. Say stay at the center, avoid unnecessary suction, and these are the tips which we use to reduce the chance of bleeding.
Ma'am, Pratibha ma'am, asking you if such a patient bleeds. Yeah, I'm coming to you only, ma'am. What do you do? I mean, you can put your point forth, and this is my next continuation. Like, you have taken all possible precautions, you have stopped the medicines, you have put on LMW, done all the bridging, and the patient bleeds. What next?
One thing I want to say that in such patient, rather than using wall suction, we use handheld suction by 50 cc syringe to decrease the suction
Suction
trauma.
capacity. Yeah.
Number one. Number two, you have put me in the my worst nightmare that the patient is still bleeding. So we start with cold saline. Cold saline is always available. One thing. Second, norepinephrine diluted with uh, cold saline. That is second thing. Third thing, vitamin K, IV Trenexa, local Trenexa. Fourth thing. And meanwhile, my team is, if the patient bleeding is not diffuse, if he's bleeding from one side, suppose I have put my needle or biopsy on left and bleeding, we turn the patient on the site of the bleeding. We want to prevent the spillage of the bleeding onto the other side. That is my most important thing. So my bronchoscopy suite is prepared. We call it as hemoptysis kit. So they are all prepared with all these things. Then come the role of Fogarty or a blocker. And in such scenario, if the bleeding is limited, first thing we are ready with that. We keep the scope at the point of bleeding. We do not suction. We apply pressure and we stand there still for 2 to 3 minutes. And we put the patient on the site of the bleed. So we try to achieve the bleeding time or clotting time. And meanwhile, all the pharmacologic agent along with cold saline and norepinephrine is being injected into the site of the bleeding. So that is the first step we do. Meanwhile, we alert our system for alternative method of controlling the airway. We, call for a better control for intubation and things like that. If we are using a thin scope, we try to convert into a thick scope, but that can be tricky because you don't want to lose or lose the sight of bleeding. It could be very tricky. You are prepared for the thick scope, you wait 2 to 3 minutes before the blood clots or the bleeding decreases, and then change from thin scope to thicker scope if you are using a thin scope. So disadvantage of a 3 mm scope is that also it does not suction blood. So that is another thing. So I think to summarize it further, cold saline, norepinephrine, Trenexa on vitamin K on one side, shifting the patient on the site of the bleeding is third side, be on the site of the bleeding without suctioning, holding the scope in position for 60 to 120 seconds to 180 seconds is the third step, and making your strategy, getting your Fogarty, your ARN blocker ready, calling somebody for intubation is your last step in salvaging such patients.
Thank you, ma'am. Thank you. I mean, you've given very nice step-by-step thing. You can use this, and this. So this is what we should be doing if you have a bleed, if in a patient who's already been on blood thinners or otherwise also bleeds or has hemoptysis. So Tampi sir, coming to you, can you just briefly describe the anticoagulants during the bronchoscopy period? Because we have spoken about heparin, we are speaking about bridging therapy. So can you just explain us in brief anticoagulants during the bronchoscopy period?
Yeah, a lot of it has already been covered, but just to put it in perspective, uh, in the peri-bronchoscopy period, the management of anticoagulant and antiplatelet agents involves carefully balancing actually. You are actually balancing the risk of bleeding during the procedure against the patient's risk of developing a thromboembolism. So this is very, very important to understand. And it also depends, as we discussed, on the type of procedure that you're planning to do. You do not have to interfere with the anticoagulants or the antiplatelet drugs. Probably if you're just going in for a check bronchoscopy or even maybe a lavage. Okay. But anything more than that, a transbronchial biopsy or a cryobiopsy, something like that, where you're expecting bleeding, then you need to take heed of the kind of anticoagulant, antiplatelet drug that the patient is taking at that moment. So by and large, most of us do not curtail eco spray for most procedures. I think EcoSpin can be safely continued. That's what the guidelines say. And in practice also, we continue to use EcoSprin in patients who are on dual antiplatelet drugs. Clopidogrel must be stopped. There's no doubt about that, and should be stopped 5 to 7 days prior to the procedure. The other anticoagulants, such as vitamin K antagonists, like warfarin, etc., should be stopped about 5 days before the procedure. And you must make sure that your INR is less than 1.5 before you proceed with your, bronchoscopic biopsies or transbronchial biopsies, etc. As far as the newer oral anticoagulants are concerned, they have a shorter half-life and typically for a shorter period. So bridging therapy could be used. We have discussed that during this time. However, since they have a shorter half-life, they can be typically stopped maybe 2 to 4 days before the procedure, or even sometimes with 1 to 2 days before. And you can, do the procedure if it's a minor thing without any major bleeding risk in that. As far as the heparins go, the the unfractionated heparin should be stopped about 4 to 6 hours before the procedure. And if the patient is on low molecular weight heparins, and it should be stopped at least 24 hours before the procedure. And having said that, you need to reintroduce these post-procedure after observing that your biopsy or whatever you've done has not caused any sufficient bleeding. So within about 12 to 24 hours, you could probably restart most of these anticoagulants and put the patient back on even keel.
Thank you, sir. And it's a very big mess now. We have so many medicines. Then we sometimes it is best to take help of your cardiologist colleagues. And as we've discussed newer things, clopidogrel, as sir said, the initial dictum was to stop it for 5 days, but now even a cardiologist, unless you're doing a biopsy or anything, they say no, you can continue. And maybe if you're doing a biopsy, 3 days might be sufficient. So be updated and take an opinion. The underlying theme would be that if you are confident of your procedure, if you have the backup, if it's a cardiac patient, take the help of the cardiologist, be prepared for the worst case scenarios for arrhythmias and bleeding. And these things have to be kept in mind that you always will need help. So keep a anesthetist or a senior standby. Now let's move on from the cardiac to the COPD patients, our own patients who come to us. Dr. Shubhra, the question is to you. So this is a severe emphysema patient and that patient needs a bronchoscopy. So what are the pre-procedure preparations and checklist you would do in such patients with severe emphysema?
So first of all, always try to have a baseline PFT. Like if a patient is FEV1 is less than 1 liter or patient saturation is less than 94, predicted FEV1 percent is less than 40 to 45, always do an ABG to look for CO2 retention, because these patients carry an extra increased risk of complication during bronchoscopy. Then always get a 2D echo done in severe COPD patient, because these patients you sometimes have pulmonary hypertension, which again add risk of again causes complication in these patients. Then optimize respiratory status first. This is obviously we will check the medication. And then one more thing, sometimes residents forget, like they tubulary focus on COPD patient and they forget to take history of other comorbid illness. Sometimes these patients are on clopidogrel and other medication and they forget to take that history before doing bronchoscopy. So take proper history of all comorbid illness. So these are the things which we can do. And if a patient is is having hypercapnia, so we can put an IV first and then optimize the patient. And if bronchoscopy is essential, then we can also use an IV to do bronchoscopy in this patient. But again, if we use NIV, sometimes there is increased risk of pneumothorax in these patients. So we should adequately use these kind of maneuvers.
Yeah, so if you have a COPD patient who needs a bronchoscopy, first check whether you can actually avoid the bronchoscopy. Otherwise, other as ma'am said, you can go ahead with doing an ABG, PFT should be done. You should be aware
Yes.
of where you're going. If the patient is not doing well, then probably an NIV can be started. And taking the history of comorbidities. A patient of COPD may have an undiagnosed arrhythmia, may have an undiagnosed pulmonary hypertension. That will add to your complication. The patient is not going to read the textbook that I am just a COPD patient. Patient can come with multiple other complications. So be aware of that. Now, Dr. Abhishek, this question comes to you. This is a patient of COPD, severe emphysema. You have done your checklist, you have checked everything, but now you're going to do the procedure. So how would you, what steps would you take to make the procedure safe?
Uh, so I think the question has been already beautifully answered by Shubhra ma'am. But one thing is for sure, I'll never attempt a bronchoscopy in a patient who's come to me with an exacerbation or is still in an acute respiratory distress. I would definitely wait for the episode to settle down, the V's to settle down, the patient to have a normal respiratory rate before I can begin with the bronchoscopy. Though our guidelines routinely tell us that there's no role of preventive or prophylactic nebulization before a procedure and it's of no use. But in my clinical experience, giving them a short dose of a short acting beta agonist or a short acting antimuscarinic does help. And this is something that we routinely do in our practice. We cannot over oxygenate these patients, especially a COPD patients. So we'll have to maintain a saturation of somewhere between an 88 to 92. If the patient requires supplemental oxygen, that is something definitely which needs to be kept in mind. If the patient is not on an LTOT, then also we need to ensure that we don't over oxygenate the patient if the patient is lying down on a bronchoscopy suite. And again, the procedure needs to be very quick. We need to ensure that the patient is not coughing insistently while you are doing the procedure, because when you wedge the bronchoscope into a particular bronchopulmonary segment, and if that segment has a subpleural bleb or a bulla, the chances that the patient might get a pneumothorax is high. So you need to ensure that the patient is not coughing while you're attempting a procedure. And best thing to do is avoid, only attempt it if it's very necessary, just retaliating it for the residents out here.
Yeah, so this is the best, this is the underlying theme. If you have a high risk patient or a special situation, if you have an alternative mode of diagnosis, probably try that. It's bronchoscopy is an invasive procedure. If possible, avoid it. And Dr. Abhishek, if I may ask one more thing, add to that, would you attempt a biopsy in a severely emphysema patient, a transbronchial lung biopsy?
I would rather not.
Not. Yeah,
We would rather try to defer it. What generally we do is, if a patient is there with a severe COPD and a lung cancer, we would directly upfront go for a PET scan, find out another source from which we can biopsy that
exactly, exactly.
lesion
Yeah.
and go ahead with that.
Perfect, perfect. This was exactly the point I was looking for. Try it for alternative routes. Don't be a hero
One
just
more thing
because
I
you have a
would also
scope.
like to add.
Yeah,
Yes. We should also keep naloxone and reversal agents always ready, though we should keep for all bronchoscopy patient, but especially for COPD patient to reverse if anyhow to reverse sedation.
yeah. So keeping,
So flumazenil and naloxone should always be in place.
yeah. Thank you, ma'am. So if let's move on to a little tricky situation. Dr. Vishal, this comes to you. Many of our COPD patients have pulmonary hypertension or they have atrial fibrillation, they have ischemic heart disease. So how will the procedure differ if there's a dual pathology?
So I think this was answered separately, but I think whatever has been mentioned for COPD, like do only if necessary. I just with one of my patient example for the last 9 years, he has had severe COPD. As Dr. Shubhra mentioned, his FEV1 is less than 40, but not hypercapnic. So recently, after 9 years, even I was a little questioning myself, why didn't I do a bronchoscopy in the last 9 years? So there was never a need to get an answer or a diagnosis. It was always an exacerbation. Sputum cultures were isolating the organism. But he developed bronchiectasis. I was really keen to get a lavage to start tobramycin nebulization. So some therapy, why he was getting a frequent exacerbations. So only in such situations where the clinical situation pushes you to get a deeper sample, I would prefer to do a bronchoscopy, and I would make sure that COPD is well controlled before I take up for bronchoscopy. Adequately give him, if needed, IV steroids or oral steroids to control the wheezing. And on the day of procedure, definitely to be as quick as possible, and preparing them mentally that if there is an exacerbation post bronchoscopy, I would admit the patient and again stick to my principles of NIV or whatever for COPD exacerbation. And for the comorbid conditions, as sir has mentioned, in the last 6 weeks, if there is any recent MI, that would apply to the same here, and I would take a cardiac consultation, and if there is a change of any drugs needed, or if AFib is there, is the AFib under control, is it under control or not under control? So whatever comorbidity you are dealing, make sure that it is controlled well, and if it gets exacerbated, what is your backup plan? So if you're working in a center which is equipped with a very active intensive coronary care unit and cardiologist always available to come to your rescue, and if needed, if these patients are positioned in intensive care, I would be happy to do it in their unit only. Or if it's in my suite, I would keep a cardiologist on call, keep all the rate control or rhythm control drugs available. If there is, if ischemic heart disease, if there is a sudden decompensated heart failure, I'll be ready with NIV, and the cardiologist should be informed for any IABP requirement. So these are some counselings which you have to do, and but best is to not to be in that position first. So if it's a real situation like even post MI, post PTCA, COPD, we get calls for a massive bleeding through through the patient is having hemoptysis. There you cannot stop the anticoagulant, antiplatelet. There is a lot of debate going on. So all these patients, place them in the center where IABP is available, and you shouldn't hesitate to talk about VA ECMO. I mean, I'm talking about a life-threatening situation where you need a bronchoscopy to clear the clots in such situations. But if it's an elective procedure, make sure all the conditions are stable and have a clear backup plan of each of the comorbid conditions. And as I mentioned, how the basics of bronchoscopy still hold, and I think that's it.
Yeah, very well said. If you have to do a bronchoscopy in a patient with dual pathology, be prepared for the worst case scenario that both can go bad. And as you said, for a cardiac patient, specifically, the sky is the limit to the kind of backup you might need.
Yeah.
So always keep a cardiologist around, at least in the same hospital where you're doing it, so that if things do go wrong and you need help, you have a help around.
Just want to add, like biopsy, the indication really matters because these days the peripheral nodule in COPD emphysema has become a very common entity. With no metastasis, obviously you have to prove and stage the patient. Even if the patient is not surgical, the oncologist is behind to start some TKI or any PDL1 drugs. So in those cases, we usually don't hesitate to do a GA with radial cryobiopsy and staging. The only thing we do in such patients is we counsel the patient for a delayed extubation. Like sometimes you cannot really extubate on the table. We avoid doing biopsies for a normal lung for any other indication, like the patient is developing any ILD also, because the chance of pneumothorax and persistent air leak is very high if in such cases. But for a lung tumor or any other tumor diagnosis in COPDs, this is the approach we do. We go aggressive on the post procedural care which we do. Sometimes we post in the morning. All those cases are posted in the morning so that they are observed till in the ICU at least till the evening and extubated in the ICU. So there are many instances we have done that. it depends on how you're coordinating your finances with the MICU in charges and all that to reduce the cost also. So you have to have a very friendly nature. I mean, very friendly environment to do all these jugards to lessen the cost as well as give the diagnosis to the patient.
Yeah, ma'am.
It's always the risk benefit, number one. Number two, as Dr. Atul Mehta says, minimum is the maximum. So you choose the most yielding procedure. If you have a mass, you have a lymph node, do the EBUS. And third thing I would like to emphasize, the oldest patient on whom I bronchoscoped is 102-year-old female suspecting tuberculosis, because giving ATT without proving is difficult, challenging, and she looks like TB and things like that. So geriatric bronchoscopy with comorbidities is a new arena. It's a new science. I'm planning to publish my data because every month, if we do 100 bronchoscopic procedures, almost 30 to 40% are above 70. So what Dr. Chitkeshi means, to do GA, not to do GA, optimizing COPD with CAD, COPD with lung cancers. So it has become a almost a most challenging part of your
Daily
practice.
practice. Yes.
Yeah,
No,
ma'am.
I would completely agree on you. So just one thing, I'll
Yeah.
completely agree, ma'am. We've just published our data of 800 EBUSs that we have done at our center, and almost 60% of the patients were above 60. So geriatric bronchoscopy is actually something that we need to look at. Yeah.
And there is not much literature, not
Mm.
any guidelines. So most of there are 80 things. Now I do routinely 90-year-old, 92, we did an EBUS to diagnose tuberculosis, and we did that. So it's just becoming a new advanced science. It is as challenging as handling central airway tumors.
And we have actually, I wanted to point it out, we have more than 2,260 people listening. And in the list of questions that I'm getting in the chat box, every special situation they have faced,
Unending.
you're trying to ask. So let's just rush
Let's
through.
have
Are the
a
questions that,
quick answer.
yeah, so we have, I mean, the common scenarios that we probably might face, which are special that I've put. So, ma'am, the next question is, Pratima ma'am, to you only. If you have a patient with pulmonary hypertension, is there a risk for doing a TBLB in such patients, and what precautions would you take?
There is a risk, increased risk of bleeding, but I try to take the usual precautions. I'm ready with my hemoptysis kit. I'm ready with to see any things to be stopped, medication to be stopped, is to be stopped. We are ready with our kit, and believe me, there is slightly more bleed, but if your steps are right, as I described, it is well controllable.
Yeah. So in a pulmonary hypertension patient, hypoxia and bleeding are the two things that you need to worry about.
Sorry
So
about that.
possibly taking all the basic precautions that we have said. So that's why we spoke about the cardiac patient first,
May I
because
add, Dr.
that
Mel,
is the yeah, sure.
for pulmonary hypertension?
Yeah.
For TBLB, especially even if it's cryo TBLB, a mild pulmonary hypertension usually is okay to go ahead. Moderate to severe is usually risky for a bleeding. But the lung parenchyma, like suppose it's early ILD, it's a naive lung, definitely will bleed more. But if it's a already set in fibrotic lung or any other consolidatory lung, so usually our tendency is to go ahead with TBLB. This is a not like mentioned somewhere, but it's our experience which we are telling. So we expect less bleeding in already damaged lung. If it's a naive lung, just early disease, definitely we are more, but always have a ant blocker Fogati in by the side if you are anticipating a bleeding, and have the control of your airway under at least Nigel with the backup of anesthetist. All those cases have to be dealt with a good airway control. This is my just input for the same thing.
And second is that consent should be more detailed and more more impeccable consent.
Yeah.
you know Consent is always very important. I give most emphasis. I give my scope to my residents more easily, but consent I take it myself, because you are predicting something. You need to emphasize that the patient might need ICU, patient might have bleeding slightly more than other patients. We don't have to scare the patient so that he says no to the procedure, but at the same time, you have to be explanatory.
So just tell everything on the day of the procedure, not the day prior to the procedure.
Whatever you do, people are going to
Yeah,
Google and have a chat GPT report ready before
yeah,
next sample.
Yeah, sometimes, ma'am, I would say the other way around. You try to scare the patient so that he refuses the procedure, so that
yeah,
your
yeah.
stress is
Just
less.
on
I
the
have
day of
never done
procedure
that,
is better.
Mehul, not in my till now, but maybe you're right.
Ma'am, sometimes the risk is too much. Like one of the
Yes,
questions in the
exactly.
chat box is the diagnostic yield versus the risk. Sometimes the diagnostic risk is yield is going to be not that much.
Yes,
Unless your management is going to change drastically,
Correct,
yes,
doing a high risk
exactly.
procedure is not worth it. Even if you
correct.
get a call for a bronchoscopy, just check whether there's any other way. Can you diagnose it? No. If you diagnose it, do a bronchoscopy. Are you going to change the management? If not, like just got a call today for a EBUS 1.4 centimeter lymph node in a routine patient for admitted for something else, the management is not going to change in that patient. So I said, does the patient need EBUS? Does the patient need EBUS with such a high risk procedure in the ICU? The answer sometimes is no. So, continuing with our respiratory patients, Kampi sir, the question comes to you. If you have a patient of asthma, a simple basic asthma patient, what precautions will you take before and during a bronchoscopy?
Yeah. If the patient is stable, if the patient is not stable and it's a very brittle asthma, I would make all efforts to try and optimize the treatment and the control of his asthma. That is the first thing. Once you have controlled his asthma well, then it depends on what kind of procedure you want to do and what is the indication. Now, mostly in asthma, these days at least, we are doing it for diagnosis and phenotyping the type of asthma, neutrophilic inflammation, eosinophilic inflammation, etc., so that you can choose your biologics according to the targeted therapy. That is one of the indications. The other one is an asthma patient, like anybody else, could also develop a respiratory infection, and you may have to do a bronchoscopy and a BAL or a lavage in these patients. Then sometimes you may have to do a rescue therapy to clear thick mucus plugs and secretions in life-threatening status asthmaticus, etc. That is a different ball game altogether. And therapeutically, of course, we are doing bronchial thermoplasty as a therapeutic approach to bronchoscopy in asthma patients. But having said that, it is very important to optimize the control first. And when you're doing the procedure of bronchoscopy or a lavage or whatever, you need to monitor the patient and prepare the patient well before you take up the patient. That is, you need to make sure that the patient is stable on the medication. You also make sure that good local anesthetic and maybe a mild sedation can be given to the patient, as was discussed earlier. If the patient needs to be, you need to be aware that the patient is likely to develop a bronchospasm, and therefore be ready with your armamentarium to correct these things if they do come up in your process. And generally, bronchoscopy should be avoided during severe acute exacerbations unless for rescue purposes, as I mentioned.
Yeah. So basically, asthma is a hyperreactive airway disease. So you're having a hyperreactive airway, also try to be right in the center of the bronchus. The more you touch the bronchus, the more the patient is going to cough, and no amount of lignocaine will help you then. So now let's move on to hypoxic patients. And Dr. Shubhra, coming to you. I mean, if you have a patient of like a patient of ARDS, hypoxic, but on O2, what are the consideration? I mean, what special precautions or any procedural changes you would do for such patients?
So ARDS, like for mild to moderate ARDS, we can take patient either on NIV or on HFNC, which also provides a low level of PEEP to have and can do bronchoscopy in these patients. But for if we ask for severe ARDS, and until and unless it is not very mandatory, ideally we should avoid bronchoscopy in these patients. But if it is necessary on mechanic and patient is on ventilator, then we have to keep in mind few things like pre-oxygenate patient with 100% FiO2 before procedure 10 to 15 minutes, and also during the procedure and also after the procedure. So 100% oxygen FiO2 should be kept. And there is not a clear cut a guideline that either you use a volume control mode or a pressure control mode. I had a talk with my friends in critical care also. So some are using the same mode, pressure control mode, and they slightly increased inspiratory pressure to generate more tidal volume. But if a patient is on volume control mode, then as soon as we put the scope, the delivery of volume is only like if we have set a 450 volume, but when we put a scope, volume delivered is only 100 ml. And there are and alarms keep rising. So what we can do, we can alarm limits can be raised, and we can take patient also on volume control mode. So these are the settings change which we can do on ARDS. But ideally, I think I don't prefer to do bronchoscopy in severe ARDS patient.
Yeah, for any patient who's hypoxic or critically ill or on ARDS on ventilator, you should have an ICU team backup and a crash cart ready. And as ma'am said, pre-oxygenate the patient, raise the venti alarms, and make sure that you're doing a quick bronchoscopy there. Most likely, you're going to do it for diagnostic purposes or maybe clearing of secretions. Try to be as quick as possible. Now, let's say the patient is not on ventilation. Dr. Abhishek, patient is on NIV or HFNC. How do you perform this bronchoscopy safely?
So I'll quickly rush through it. So if a patient is on HFNC, I'll first ensure that I'm giving the patient the maximum flow that is there on the setting and the patient is tolerating. Somewhere above 50 liters per minute is recommended. I'll ensure that the patient is adequately pre-oxygenated before the procedure, is oxygenated adequately during the procedure. So I always will try to keep the FiO2 of 1. And I'll try to take an oral route, not a nasal route, because we'll be obstructing the flow of the HFNC over
HFNC.
there. And even when we are using a bite block, common approach that we use is we try to cover the bite block with a glove, and we make a small incision using a scalpel so that the loss of PEEP, if a FiO2, if a HFNC is delivering a flow of 60 liters per minute, a PEEP of somewhere around 4.8 is generated. And if you're not using a glove or any other cover, the bite block will cause a loss in PEEP. So a glove with a small incision can go a long way in ensuring that an adequate PEEP is delivered. So these are certain things that we do at our center. As far as NIV goes, again, we'll ensure that we are pre-oxygenating the patient adequately. We are oxygenating the patient adequately during the procedure as well with an FiO2 of 100. The PEEP or the EPAP would be somewhere between 5 to 10. The IPAP would be somewhere between 10 to 15. I would love to keep these patients on a pressure control mode rather than a volume control mode, so that when I'm introducing a bronchoscope through the NIV, there's no loss of tidal volume. And I'll want to raise the alarms of the pressure to such a bit that I can ensure that an adequate tidal volume is been generating to these patients. And obviously, if you're doing it through an NIV, we have those specialized.
Abhishek, you became muted. Abhishek, you're muted. Yeah.
Sorry. Yeah. So the oral
Yeah.
approach is generally preferred, but sometimes we also do a nasal approach even through an NIV. But we'll have to ensure again, if possible, and if your center permits, do have an anesthetist with you while you're attempting bronchoscopy in such high-risk patients, because while you are concentrating on the airway with a bronchoscope, the anesthetist can take care of the vitals while you're doing the procedure.
Yeah, so you can just put, you get special adapters for NIV, like you get swivel adapters for intubated patients, you get special NIV masks. Lift up the mask, put it through the adapter that you have. If you're doing nasally, go nasally and then put the mask again. Sometimes these small things help. And the best thing is to have the anesthetist, as you said. Otherwise, the intensivist on call should be there to help you out in such patients. Now, let's move on to another area of concern, a special condition called thrombocytopenia. Dr. Vishal, if a patient has thrombocytopenia, what is a safe level to perform a bronchoscopy if you're performing like a biopsy or this thing, TBNA, and how do you achieve that level?
So, especially for TBNA or TBLB, we would prefer a minimum of 50,000 platelet count. We would do a APTT and check if the patient is already having any bleeding manifestations. Definitely, if bleeding manifestations are high, APTT is high, so we prefer to transfuse the patient platelet transfusions. I would generally prefer to give it in the recovery just before shifting to the suit. And I recollect, I mean, there were not many TBLBs done for such patients, mandating that I have to do a TBLB, but definitely I can recollect many EBUS done for thrombocytopenic patients. All we did was checking if it's minimum of 50, the APTT is under APTT is corrected, platelet transfusions just before the procedure. For bronchoalveolar lavage, unless the patient, I mean, if the platelet count is too low, like for less than 20,000, like any dengue case or any bone marrow transplant patient, or these are the patients which may have severe thrombocytopenia, they would already be having mucosal bleeds. So doing a bronchoscopy without adequately correcting would land up in a small mucosal erosion causing a large bleed, landing up in new complications. So try to avoid doing bronchoscopy in such patients. If it is definitely needed, please correct with platelet transfusions. Even though you give platelet transfusions, keep your backup ready with APC. If there is a mucosal ooze, be ready to immediately coagulate the area, spray the APC, and do it in a very controlled settings with a backup of igel, deepening the anesthesia and taking over the airway control. Suppose the patient is already having a bleed. In such patients, you are going for a therapeutic intent, then definitely you have to go in, keep everything ready, start the procedure directly under GA with igel, and then identify the source. If it's in the bronchi or trachea, try to correct, I mean, coagulate the area. If it's a deeper parenchymal lesion, we what we would do is we place a Fogarty blocker there, and then leave the blocker and ventilate the patient in the ICU. So this is for a patient of a therapeutic. For diagnostic, definitely minimum of 50 for biopsy, and less than 20 do not attempt, and more than 20 bal no correction needed. If it's a lavage, definitely we don't correct that.
Use
Yeah,
oral
thank you.
route.
So that was a very,
Number
yeah,
one,
Pratham.
use oral route. Second, do not use wall suction, use syringe suction. Don't
Yeah.
go by nose.
Even one thing which probably I've not mentioned, I've not prepared the question for it. In a CA lung, if you have SVC obstruction, prefer the oral route. Going through the nasal route in SVC obstruction will definitely cause bleed.
Bleed.
Uh, Once you face such complications, you learn it,
Exactly.
So
Yes.
coming to ma'am, Pratibha ma'am, it's now I'm coming to you. Now let's move on to a liver cirrhosis patient. Patient needs a bronchoscopy. What will you look out for before and during the bronchoscopy?
Platelets will also always be low. So for me, platelet in cirrhotic patients are very good patients. They are not so bad as they appear to be. But INR has to be monitored. INR has to be less than 1.5, number one. Number two, he should not be decompensated. If he's not a decompensated cirrhotic, do not, in any way, I try not to do an biopsy in such patients. Try to avoid biopsy. So again, my principle is minimum is maximum. So lavage with TBNA is okay, or a EBUS is okay. Biopsies I try to avoid in CLD patients. I'm ready with my FFP, fresh frozen plasma with vitamin K, and maintaining the INR. So INR is an important parameter in CLD patients.
Yeah, and if there's too much of ascites, you might actually tap it a little bit before you go in for procedure. That might also help.
That if it has a too big a tummy and is pressing upon the diaphragm, do that.
Yeah, definitely. Small things you pick up. You have, as if you have any other system involved, let's keep a theme. Remember the theme, whether you need the bronchoscopy or not. Is there any alternative way? And take help of the specialist from where the patient has come. Like if it's a cardio patient from a cardiologist, if it's a liver patient from the hepatologist. Now, moving on to the other organ, Tampi sir, the question comes to you. If a patient is of a chronic kidney disease, CKD, diabetic, many diabetics have CKDs, and you are seeing more and more geriatric patients coming for bronchoscopy. So, in a patient of CKD, how will you plan a bronchoscopy procedure?
Yeah. CKD patients are often immunosuppressed, and many of them are on hemodialysis, antiplatelets and anticoagulants, etc., etc. However, having said that, they're generally safe, and bronchoscopy is useful in these patients, particularly diagnostic, to try and find out what kind of an infection or um, problem you're dealing with. So, having said that, the most important thing that you need to consider is the bleeding risk. And here, not only that we should know in CKD, there's not only a low platelet count, it's also the platelets have a dysfunction. And so you may have adequate numbers, but they may not be effective clotting. So this will also need to be considered when you're doing your procedure or planning your procedure. Mostly in CKD patients, what I have come across, we get away with just doing a bronchoscopy and a bronchoalveolar lavage. You rarely need to do a TBNA or something like that. But having said that, it is important that you do the basic workup for the bronchoscopy as you would do in any patient, and make sure that the patient is not in fluid overload. Hemodialysis has been done. There is circulating heparin in the circulation. So you must also consider that as an anticoagulant, and the patient may bleed in case you do a biopsy or a needle aspiration. But however, these are much less. And in my practice, what I felt that if you do a bronchoalveolar lavage with probably a needle aspiration is all that you probably require to arrive at a conclusion as to the diagnosis in these patients.
Yeah, and you have to be very careful about using the anesthesia also. If you're using an IV anesthesia for any reason, a CKD patient might not respond so commonly as he would. The sedation might take a longer time, or you might face with hypoxia during the procedure. Now, Shubhra ma'am, if a patient of CKD, Tampi sir said lavages should be enough, but let's say the patient requires a biopsy and there's a BUN creat is high. Is there any level of BUN creat or platelet where you would choose to do or not do a biopsy?
So already discussed level of platelet is same as like 50,000 for CKD patient also. But again, the problem is of platelet dysfunction. So more than a number, it is dysfunction that matters. However, BUN and creatinine, so BUN more than 30 and creatinine more than 30 is actually one of the relative contraindication. So in fact, I will like to say by this webinar, in fact, to everybody that until and unless you don't have facilities of rigid bronch and adequate control of hemoptysis at your place or CTVS backup, kindly don't do bronchoscopy, especially in azotemic patient, creatinine more than 3. Sometimes these patient can bleed heavily, and a complication rate can be as high as 45% according to some literature. So what is suggested is like do a prior dialysis 24 hours before the procedure, use only oral route, never a nasal route. And you can use, if you are doing TBLB, then desmopressin IV or intranasal, that is also available, and that can be used to reduce the risk of bleeding. So these
Yeah.
things we can do for CKD patient.
So also one thing to remember that if you're doing a dialysis, many a times heparin is used for dialysis. So you need to be careful when you're doing a biopsy in such patients. And as the general theme, keep everything as a backup because these seem innocuous, but these are high risk patients. Now,
And also, just
yeah,
one,
ma'am.
I will just take a minute.
Yeah, ma'am.
Just there is a very beautiful article published by Dr. Ravindra Mehta sir, and that is a journal Innovation. And he did bronchoscopy in around 100 cases of azotemic patients. And what he used, which I actually have no experience, but I'm just sharing, that he used a guided sheath as an extended working channel, and that guided sheet was introduced through the bronchoscope, and then biopsy forceps was introduced, and that guided sheath act actually as a tamponade to control bleeding in TBLB patient and azotemic patient. So that is a very good article. I was going through that article once I got the chance to have this webinar. So that is very good thing one should go for.
Dr. Mehul, may I add in?
Yeah, sure.
Yeah, just in CKD, make sure they are not in fluid overload state. Sometimes they are on twice dialysis or thrice dialysis. If we, I make sure that I do the procedure on the day of dialysis, immediately post dialysis. Like simple clinical examination or JVP. These are the things which you can check before, because there are instances where post bronchoscopy they went into fluid overload state, stress, cardiac failure, uh, because of, if they're already in a overload state. So make sure they are adequately in even balance before just attempting bronchoscopy in CKD patient.
Yeah, very well said. Very well said. Now let's move on to our next special situation, which is pregnancy. And Dr. Abhishek, is bronchoscopy contraindicated in pregnancy? And if you're going to do, what are the pre-procedure preparations, complications that you would keep in mind?
So to answer the first question, bronchoscopy is absolutely not contraindicated in pregnancy, but yes, you should try and avoid it as much as you can. We are fortunate to have a very large obstetric critical care unit at our facility, and we routinely perform bronchoscopy in pregnant patients where it's indicated. Just to put in a caveat, we definitely try to avoid it as much as we can, like you said. But in case it's indicated, we have a multidisciplinary approach while we are doing it. We have an obstetrician who stands by the bedside and monitors the fetal heart rate. We have an anesthetist who stands by the bedside and monitors the vital of the patient who is pregnant. We perform bronchoscopy in such patients, even if the patient, this is our institutional policy, and we do that using an HFNC to ensure that no amount of hypoxemia is taking place while we're performing a bronchoscopy. Then again, we try to minimize the sedations as much as possible. We generally deliver a local anesthesia. If you're doing a BAL, we don't give either a fentanyl or a midazolam in such patients. And we try to achieve a scope in and a scope out time of less than equal to 5 minutes. So we ensure a very, very quick procedure in such patients. And we definitely don't do a biopsy or a TBLB or an EBNA or any such things, and we definitely only do it for a ball. That is what we do at our institute.
Yeah, very well said. When I was making this question, contraindication in pregnancy, my wife is an obstetrician, so I cannot have an absolute contraindication. But yes, very well said. The indication aspiration. The lower sphincter, esophageal sphincter is going to be a little lax in pregnant patients. So be careful about aspiration post procedure also. So the last question that I have made comes from Dr. Vishal. This is about infectious patients, like HIV positive, Hep B or Hep C positive patients. What special care needs to be taken, since these are also special situations when you're doing a scopy?
Yeah, definitely. Uh, as a sitting in a, quaternary care, we get patients where the outside um, setups are not encouraging to do these procedures. But
Hmm.
at our center, we don't keep anything separate for these procedures. Only thing we make sure is adequate protection to the bronchoscopist and the healthcare staff, and adequate disinfection of the equipments. So we use all the standard protection glasses, gown, mask, preferably N95, and posting the case to the end of the day. Like we, post procedure, usually the suit is given for fumigation. So we make sure that the procedures are done at the last
Hmm.
last procedures of the day, and we usually cover the area around the table, the ground around the floor around the table also, just to make sure that any, because these are aerosol and spillover things. So these are the precautions we take. And disinfection, standard routine disinfection is enough to sterilize our scopes. And even if anything which accessory which you use has to be discarded. And so those are the precautions which we take for even if it is a TBNA or a TBLB. So we just discard those equipments, because sometimes if it, even if it's a cryo probe, We usually tend to use cryoprobe 4 or 5 times, but if we use it for a positive patient, we discard the patient and use adequate equipment. That's it.
Yeah, so I mean, maybe in future you may have disposable scopes which can
Disposable
be used
pump.
for this. Yeah, but as you said, at least the equipments otherwise from the scope that you use, that the biopsy forceps, the needles, those needs to be discarded. So those were the end of questions which I had for you guys. Now there are a lot of questions in the chat box, but many of them we have covered in some or the other way. So I'll just rush through them, which we have not covered. So first question from Dr. Mohan in Lucknow. I mean, what are modification needed for bronchoscopy in patient with difficult airway anatomy? We've discussed, or a tracheal deviation. A tracheal deviation patient, you might put pressure and try to get the trachea in the center and probably help. Obviously, under vision, it should be easy. Next question from Dr. Amit. We have already spoken how to localize and control bleed. Pratibha ma'am has already spoken. Ma'am, you want to add anything to that? How do you localize and control bleed during bronchoscope? Control you have mentioned. Localize, how do you do it?
By vision,
That's it.
just systematically just clean all areas, and from where the blood gushes out after cleaning is the area of the bleed.
Perfect. Perfect. Next question. What are the key bronchoscopy clues in suspected? We'll take it later. Okay. We have already taken a role of bronchoscopy in ICU or mechanically ventilate patient. When does benefit outweigh the risk? Only when your management, this is the general theme. In any high risk patient, if your management is going to change drastically, only then you do a scopy. Simple as that. This is an interesting question from Jaipur. When should bronchoscopy be avoided during necrotizing pneumonia or a lung abscess? Anybody wants to take it? Yeah, ma'am.
I think you should not avoid it.
Exactly.
You
So
should do it
spillage,
and
probably
get the bug.
So probably spillage is probably what he's worried about. So you can use, covered catheters to make sure that you're not spilling it out and be very quick in your procedure. And the affected side can be put down so that you
Put
don't
down,
have
yeah.
aspiration on the
It
other
does not
side.
have spillage, and use a therapeutic scope. You can
Therapeutic.
suction most of it.
Yeah.
And in fact, sometimes there can be an endobronchial obstruction that is leading to post-obstructive pneumonitis or lung abscess. So then
Correct.
again, it becomes essential to do bronchoscopy.
Yeah.
Yeah.
So
It is rather helpful, most of
helpful.
it.
Helpful. Yeah.
Yeah.
If it's a communicating abscess, definitely surgical management will help.
Yeah. So indication of emergent bronchoscopy, how, okay, I'm just seeing as we are seeing bronchoscopic techniques we have done. Okay, how to approach in a patient with nasal intubation after commando surgery. Okay, this is, since it is written ma'am, any of the ma'ams can take it. How do you approach in a patient with nasal intubation after commando surgery with lung collapse requiring bronchoscopy? This is from Dr. Gopal Krishna in Bangalore.
I have
So,
shown you how to take it. I have the video
yeah,
is it's you have to do it like any
yeah,
other. And the bronchoscopy is your guide. The scope is your guide.
yeah. So it should be easy.
So it
What
is
PF?
same like whether it is commando or non-commando.
Not
Like nasal
non-commando.
intubation,
Yeah,
the way is same.
yeah, yeah.
So I would like to still add, this is probably from personal experience, that you should know both ways of doing a bronchoscope. Many people still prefer and do only oral. They are not very confident with nasal bronchoscopy intubation. So that should change. You should know both the routes. What is the PF ratio that needs prior to intubation before bronchoscopy? If it's an emergency scopy, just pre-ventilate the patient and go ahead with it. And if it is a planned procedure, then make sure that the patient is least hypoxic as possible. Role of bronchoscopy in athletics in the ICU. We took it in the last webinar, so I'll be not taking it. Contraindication we to avoid. What should every pulmonologist know before attempting bronchoscopy in special situations? This is all we have been talking about, so we should know
When
when to
not
do,
to do.
when not to do. That is the best answer. Okay, informed consent. How does an informed consent change? Do you take any special consent? This is something which I forgot to ask. Do you do written consents or you do video consents, any such thing at any place anybody is doing it?
Yes, we usually have a printed format,
Hmm.
but any extra information we usually write it in the regular notes or case sheets and also take a signature there.
Yeah,
So
and the
that
best
we do
thing.
in all patients, but we emphasize and a specific complication if we are foreseeing we mention it, the percentage, explain to so and so person and in detail about this particular complication like bleeding in, CKD or CLD or hypoxia in a, the risk benefit ratio is made clear or, discussed in detail with the family. It's very important to do it and mention it as well.
One more thing I would like to add, when you're taking consent, you have to mention on paper, this is for every bronchoscopy, not even for high-risk bronchoscopy, alternatives have been discussed.
Discussed,
And you
yes,
have to mention that you have discussed the alternative
as well.
as well. And a
Mehul,
video.
it is so good to see that we have 2,264 logins.
Yeah,
So
ma'am, that's why the amount of
really,
questions is too much. I don't think we can cover it in two webinars. I'm just seeing with the ones which we have not directly addressed. So this is important one which we have not addressed directly. Patients on inotropic support. What precautions should we take? Dr. Anil from Bhopal wants to know.
You should
Anybody?
avoid doing bronchoscopy in a patient on high inotropic support. Don't do it. You will lose the patient post procedure because of various arrhythmias or, cardiac issues.
Yeah, so unless you're doing it for lung collapse and your all your
Collapse,
Yes,
correct.
yes.
Yeah. Where hypoxia
non-invasive
improves or you are
If the
going
hemodynamic instability is due to the, if it's a
collapse,
therapeutic
exactly.
intent, yeah.
but it
And
never
if
happens. Hemodynamic instability never happens because of a collapse.
no, ma'am. So the
So,
point is, if you have other means which have failed, and maybe
right.
opening up the lung might benefit the patient, at least ventilation wise, only then you should
Then you
do
should.
it. Yeah.
So very rarely you should attempt if on high inotropic support. You should avoid doing bronchoscopies.
So minimum PA to FI2 is okay. We have spoken about choice of sedation, ARDS, we have spoken. Should ECG be done routinely before every scopy? My answer would be yes. If it's a patient of elderly patient and an ischemic heart disease patient, young patients may not need, every patient does not need an ECG. HFNC we have spoken, NIV we have spoken, desaturation, okay. Too many questions still popping in. What are the common pitfalls during NIV guided bronchoscopy? Dr. Abhishek, you spoke about NIV. What are the common pitfalls?
So you tend to have hypoxemia if you are not pre-oxygenating the patient, if during the procedure the FiO2 is not 100%, if you're not maintaining an adequate EPAP and an IPAP, you cannot do a bronchoscopy on a volume control mode because once you open the lid of the connector, the volume will be lost and adequate tidal volume will not be generated. So you have to do it on a pressure support mode or a pressure control mode, even if you're doing it on an NIV. So these are certain things that you need to keep in mind, and the procedure should be very quick.
Yeah,
You,
thank you. Yeah, and preferred scope in massive hemoptysis. If it's a planned one, a rigid is always better, but a flexible is your best friend if it's an emergency one.
And with
Um,
the larger diameter, larger
Therapeutic.
yeah,
suction channel,
adult
Therapeutic.
50
scope.
mm
Yeah,
suction channel.
the best, with the biggest scope that you can have in that setting. Okay, high scope. Why is bronchoscopy avoided in acute asthma? The bronchospasm will worsen. And drug mandate, we have spoken. Common cardiac complications, we have spoken. Role of cold saline, done. Okay, I think we have covered most of it. Indication of balloon tamponade, madam has already spoken about it. Why is suction minimized in hemoptysis? Probably you'll bleed it more. You just have to make sure that you're there to just clean the. I mean, this is also up to debate. If there's a clot, would you remove the clot or you want to keep the clot there?
Do not remove the clot.
Do not remove the clot. I'm looking for the answer. Um, whom to avoid transtracheal lignocaine? I usually don't prefer giving. I'm sure Pratibha already mentioned that she doesn't. Anybody prefers giving transtracheal lignocaine?
Dr. Mehul, I used to do in the beginning days of the career. I mean,
Hmm.
like only when the trachea is very evident and you can easily palpate the cricothyroid area. But later on, that has been an obsolete for our practice right now.
do not use transtracheal unless and until, means it is not part of the scheme. It is totally old fashioned. Patient complaints of pain later on for weeks. Patient complaints of pain. When I learned bronchoscopy, my mentor used to do that, because he was the pioneer of bronchoscopy in India, Dr. Kulpati. He would give transtracheal himself in all patients, but they came to OPD with tracheal pain, and it is not being practiced at any of the standard of, center of standard care.
Yeah, so I mean, we've had too many questions. I mean, there are majority of the questions are variations of the things that we have spoken. So I probably would be skipping them, and I'm sure there are going to be multiple special situations which will arise in future. I've just tried, and we have just tried to give you an overview of things which commonly you would see. You might have an HIV positive patient with CKD, CLD, and an ischemic heart disease all coming together for one lymph node which needs to sample, or one lavage which needs to be taken. So such situations you have to take it on their merit. So I thank all my panelists and my speaker, Dr. Pratibha Gogia. I also thank Olympus and Mankind. And before we wrap up, I want one line of advice from all of you, starting with you, Pratibha ma'am.
Uh, Minimum is the maximum. So plan your procedure, do the minimum, and try to get the maximum out of it.
Thank you, ma'am. Tampi sir, any word of advice?
Yeah, the advice is, because of the topic is intubation bronchoscopy. So therefore, before you do bronchoscopic intubation, you must study the airways very well, prepare yourself for the procedure, and also be ready with your, the emergency kit required to resuscitate the patient in case you land in trouble.
Yeah. Shubhra ma'am, your word of advice.
Don't try to be hero in all high risk bronchoscopic condition until and unless you don't have facility of rigid and CTVS backup. So those who are starting their work, and at least don't take high risk cases until you don't have backup.
Yeah. Dr. Abhishek.
So in all these special situations, always try to have a multidisciplinary team, have an anesthetist, have an intensivist. If you're doing it in a pregnant patient, like I said, have an obstetrician on the standby, and always try to achieve things via a teamwork. Never go alone.
Yeah. Dr. Vishal.
So before going for special, if you are a beginner, try to be perfect in your regular situations. So keep practicing in regular so good so that the special also becomes your regular. So I try to keep your basics very right in the basic bronchoscopy skills.
Yeah. So the bottom line is, see whether the bronchoscopy needs to be done. Don't be afraid or ashamed to ask for help. You can always take an help of a senior pulmonologist in your team, or an anesthetist, or an intensivist when you're doing such procedures, at least for the first few procedures. And every patient is special. Remember that sometimes a routine bronchoscopy can turn out to be a mess. So be always prepared for the worst case scenario. So
And as
thank
a
you all. Thank you for,
pulmonologist, I think everybody should know intubation at least. They
yeah.
should at least attend a workshop where they should know basic intubation. Each and every chest physician, each and every resident should know.
Ma'am, actually, an MBBS person ideally should know, and we have come through that now. That at least a pulmonologist should know, at least. Yeah. So thank you all. Thank you for staying till this late, and thank you to all the audience, all 2264 of you, and for all the questions. I'm sure there will be some special situations which probably we could not have answered. This is one webinar, and you'll have hands-on workshop. That time you can, we'll have all of these specialists with you. You can ask as many questions as you want at that point. Thank you for being here. Thank you, Olympus. Thank you, Mankind, Mr. Nitin specifically. And we'll see you in the next webinar, which will be the 8th one. And take care. Good night.
Thank you. Thank you so
Thank you,
much.
Mehul, for
Bye.
Thank
excellent
you, I.
moderation.
Thank you.
Thank you. Thank you, Mehul.
Thank you, ma'am.
Okay. Good night. Bye.
Good
Good
night.
night.
Bye.
Bye. Good night. Bye bye, everybody.
Bye.
Bye,
Bye.
Shubhra,
Good night.
Abhishek,
Bye.
Sir,
Bye.
Thambi
Bye.
Bye.
sir, and
Bye.
Bye.
See you.
Everyone, good
bye,
night.
Mehul.
Good night.